of Wilson's disease, it is an autosomal recessive condition where you can see this ATP7B mutation, right? So what happens here, there will be excessive deposition of copper in cornea, liver, brain and kidneys. Normally what happens, the copper will be absorbed in the small intestine and it binds to the albumin and it gets incorporated into the ceruloplasmin, and then it is excreted out through the bile. But in case of Wilson's disease, this copper is not getting incorporated into the ceruloplasmin, which leads to degradation of the ceruloplasmin, right? So it is excreted out into the urine. So there are low levels of this ceruloplasmin. So what is happening in the Wilson's disease? There is ATP7B mutation which is impairing the biliary copper excretion. So copper is not incorporated into the ceruloplasmin, so there will be degradation of the ceruloplasmin which will cause this low levels of ceruloplasmin, which is a classical sign which you can see in this Wilson's disease. So in the Wilson's disease, there is low levels of ceruloplasmin. Keep that in mind, right? So this free copper, which is not bound to ceruloplasmin because of the degradation of ceruloplasmin, goes and accumulates in the hepatocyte and then it leaks into the bloodstream, depositing in the brain, cornea and the kidney. So what are the clinical features which you can see? So if it is depositing in the liver, you can see this hepatitis, hepatomegaly, cirrhosis, acute liver failure and all. If it is depositing in the brain, you can see this gait instabilities, tremors, Parkinsonism, dystonia, dysarthria like slurred speed, and then later depression, cognitive decline can also be seen. And this copper, if it goes and accumulates in this cornea, it is a characteristic Kaiser Fischer's ring can be found in the Wilson's disease and also associated with sunflower cataract. Other things are hemolytic anemia, delayed puberty, osteoarthritis, cardiomyopathy, hypoparathyroidism, right? So all this can be seen. If it is going and accumulating in the kidneys, it will cause renal tubular damage, osteoporosis. So these are all the different clinical features which you can see, right? Coming to the diagnosis, there will be low levels of ceruloplasmin because of the degradation. So normally it should be from 20 to 35, but in case of Wilson's it will be less than 20, right? So if it is less than 5 mg per dl, it will confirm the diagnosis of Wilson's disease. If it is less than 10 mg per dl, there is a high possibility that it is a Wilson's disease. If it is between 10 to 20, that it may be Wilson's disease or any other thing. If it is greater than 20, it is never a Wilson's disease. So because the normal levels are 20 to 35, about 20 means the ceruloplasmin will come under normal levels. So the ceruloplasmin levels are not normal in case of Wilson's disease. Always this will be low. Ceruloplasmin levels will be low in case of Wilson's disease. Now coming to the total serum copper. So total serum copper is made by 10% non-ceruloplasmin bound copper and 90% ceruloplasmin bound copper, right? So what is happening in case of Wilson's disease? There will be reduction in the ceruloplasmin bound copper. So automatically this non-ceruloplasmin bound copper or the free copper will be increasing and it will be excreted out through the urine, and some of it gets deposited in the liver, kidneys and brains and all, right? So now if you look at the values, the total serum copper, which is mostly made up of 90% of bound ceruloplasmin copper, it will also decrease. Non-ceruloplasmin copper will be increasing and it is excreted out through the urine. So there will be 24-hour urinary copper also increase, right? And this 90% ceruloplasmin bound copper will be decreasing because of the degradation. So coming to the diagnostics, so in the labs you can see this serum ceruloplasmin low, less than 20 mg per dl, and urinary copper will be excreted out, which will be greater than 100 mg per dl, and then increased hepatic copper content, right? So it is a gold standard. In the hepatic, you can see this copper. So in the MRI, there will be face of giant panda and also Mercedes-Benz sign. It is important to remember. Mercedes-Benz sign can be seen in MRI and also face of giant panda can be seen. And abnormal crosstal hyperintensity can also be seen. So coming to the treatment, we'll give this D-penicillamine. So this penicillamine can rarely cause myasthenia gravis also, right? So the side effects can be myasthenia crisis, lupus, neurotoxicity, bone marrow suppression, rash, right? So penicillamine can be used, and also you can also use this tetrathiomolybdate and zinc acetate or the zinc sulfate. So this zinc is mainly used in pre-symptomatic or the pediatrics or the pregnancy conditions. And also along with this D-penicillamine, zinc and the tetrathiomolybdate, you can also use this dimercaprol, ammonium tetrathiomolybdate and potassium sulfate. So all this can be used. So coming to the prophylaxis, we'll screen this whole family because it is an autosomal recessive condition, and also we'll check the serum ceruloplasmin, which will be low, and 24-hour urine copper, which will be high. And coming to this Kaiser Fischer's ring, it is not diagnostic to Wilson's. That means it can also be found in other conditions like chronic liver disease, primary biliary cholangitis and primary sclerosing cholangitis and familial cholecystatic syndromes. So in something related to cholecystatic and the bile, you can see this, right? So chronic liver disease, PBC, PSC, and familial cholecystatic syndromes. So you can see this caseous fleecious ring. So what is happening here? The copper is getting deposited in the cornea in the Descemet's membrane, right? So which will lead to this golden greenish brown color at this corneoscleral junction, and also it can be associated with sunflower cataracts in case of this Wilson's disease, and it is disappearing on the treatment. It is an important point to remember. And also if the liver transplantation is done, this caseous fleecious ring will go away. Coming to the treatment, you can administer this penicillamine 500 mg at 0 hours, and at 12 hours also you can give this 500 mg. So urinary excretion of copper will be greater than 1600 mg per day. So this is about Wilson's disease. So the things you have to remember in this Wilson's disease is autosomal recessive condition, ATP7B mutation, right? So excessive deposition of free copper in the liver, brain, kidneys and the corneas. So here the copper is not incorporated into the ceruloplasmin, which leads to the degradation, which leads to the low levels of ceruloplasmin. So all these things you write: tremors, gait, ataxia, dystonia, and hepatitis, hepatomegaly, cirrhosis, liver failure, and this depression, caseous fleecious ring, and sunflower cataract, right? Renal tubular damage also. So ceruloplasmin levels will be low, write about it. So normal levels will be 20 to 35, so below 20 will be Wilson's disease. And now coming to the labs, the gold standard is hepatic copper content. That means in the liver there will be copper content more. So that is the gold standard. In the MRI you have to remember this Benz Mercedes sign and the face of giant panda sign, right? And this criteria is used for the diagnosis. Coming to the treatment, D-penicillamine can be given, and the important complication of this D-penicillamine is myasthenia gravis, and also tetratiomolybdate, zinc acetate or zinc sulfate for the pregnancy and the pre-symptomatic and the maintenance therapy. Zinc is only preferred, and in the prophylaxis you'll do this serum test and the urinary test. This rings, caseous fleecious ring, can be seen in the Descemet membrane deposition at the corneoscleral junction because of the golden greenish brown color deposition of this copper, right? So it disappears on the treatment. That is an important point to write in the exam. It disappears in the treatment, and this not only seen in case of this Wilson's disease, but it is also seen in chronic liver disease, PBC, PSC, familial cholecystatic syndromes. Bye.